So we are doing another case of oral mucosal lesions from ODELL, which is case number 41, which is on page number 227. So this case, the highlighting, the introductory line they have given, or the topic headline is blisters in the mouth. So this is a 63-year-old female patient of your general dental practice, reports severe oral discomfort with blistering. Identify the cause and outline the appropriate management. The appearance of the gingiva is as shown. Complaint is the patient complains of soreness involving cheeks, gums, and palate, which started 12 months ago and has increased in severity since. She reports blisters that burst to release a clear fluid. So, see, this is cheeks, gums, palate, the region you see 12 months ago, and it has increased in severity. So, it is not so fulminant that it became, difficult for her to have drinks, have food for over 12 months. So it is a chronic development. Most of the ulcers are not so chronic development. Either they come and go, or they come in a very fulminant manner if they are true ulcers. But these were blisters that burst to release clear fluid. So something like vesicles, blisters. She is able to tolerate soft foods in her diet, but avoids anything hard or sharp, as even minor trauma can cause blister to burst. When a blister bursts, it leaves a painful ulcer that is slow to heal, and brushing of teeth is painful and associated with bleeding. She denies any cutaneous or genital blisters, so skin lesions are absent. The history is negative for dysphagia and odonophagia. So painful eating or difficulty swallowing does not exist per se. However, she describes recurrent nosebleeds and nasal crusting. So nose lesions are also involved along with oral lesions. There are no ocular symptoms. The only relevant past medical history is hypertension, for which she takes angiotensin-converting enzyme inhibitor, which is ramipril. Now, extraoral examination, nothing can be found, with no cervical lymphadenopathy, and eyes are also normal. So when they are talking of the eyes, nose, mouth, pemphigus should be coming in our mind. Oral mucous membrane pemphigoid, pemphigus, these lesions. The appearance of the gingivae is as shown in the figure, demonstrates extensive gingival erythema of the buccal and the labial gingiva in all quadrants. There are ulcers on the posterior gingiva on the right side. Inflammation is generally limited to attached gingiva, as we can see in here, but extends onto the alveolar mucosa and into sulci in several places. So it can reach sulci and alveolar mucosa. What is differential diagnosis? Causes of blisters, which is the most important table here for this chapter, are listed here. So first is mucous membrane pemphigoid. Mucous membrane pemphigoid is an autoimmune disease with autoantibodies targeting various components. So it is a frank autoimmune disease. Various components of the basement membrane are targeted, such as bullous pemphigoid antigens. Autoantibody binding activates complement and attracts neutrophils and eosinophils. These immune cells are causing the degradation of the basement membrane and separation of epithelium from connective tissue. Edema fluid collects in the space to form a blister. So classic autoimmune body cells activating, separating the epithelium above, creating an ulcer in which edema fluids, blister. They create a blister in which edema fluid penetrates and creates these blisters. Now we have pemphigus vulgaris, which we have studied in the last session, it was having the white striae-like appearance on both sides of the buccal mucosa. So it is also an autoimmune disease with immunoglobulin G antibodies, autoantibodies directed against desmoglein 1 and 3, which are adhesion molecules in desmosomes that hold epithelial cells together. So there was a thing which is prominently word used for pemphigus is acantholysis, and spaces in the epithelium fill with the fluid to form blisters. Mucosal lesions are associated with a predominance of autoantibodies against desmoglein 3 and cutaneous lesions with a predominance of autoantibodies against desmoglein 1. Sorry, we didn't read pemphigus vulgaris in the previous one. It was lichen planus. I got confused with this. These two are very, very related. Mucous membrane pemphigoid and pemphigus vulgaris are the ones which are very related. Then we have differential diagnosis of it is bullous subtype of lichen planus. This is a T-cell mediated reaction, possibly autoimmune or possibly directed against haptens or extrinsic antigens in basal cells of the epithelium. Basal cells are killed, and because they maintain the basement membrane, the attachment of the epithelium to the connective tissue is weakened. Usually, the epithelium becomes thin and ulcerates because the